I'm really delighted to be here today to talk about how randomized evaluations can help us answer open questions in healthcare policy using the example of workplace wellness. I'd like to begin by acknowledging support for this work by JPEL North America, as well as the National Institutes of Health, the National Science Foundation, Evidence for Action, which is a program of the Robert Wood Johnson Foundation, and the Upjohn Institute. The conclusions that I expressed today are my own. So as the backdrop for this study, rapid growth in medical spending has driven policymakers and employers to search for ways to reduce healthcare costs. And one widely touted solution is workplace wellness programs, which have become popular among US employers that offer health benefits to their employees. The wellness industry has grown over 300% since 2011, and the coverage of these programs is broad. 83% of large firms that offer health benefits also offer a wellness program, and these programs now cover over 50 million US workers. Underlying the adoption of these programs is a belief or a hope that wellness programs can improve employee health, increase their productivity, and reduce healthcare costs. The programs have also been popular among policymakers. In 2009, the CEO of Safeway wrote an influential Wall Street Journal article stating that workplace wellness programs had kept their healthcare costs flat for 4 years and could reduce the national healthcare bill by 40%. Now, this pitch enjoyed bipartisan support, and in what became dubbed the Safeway Amendment, the 2010 Affordable Care Act adopted provisions to encourage the use of wellness programs by allowing firms to offer large wellness incentives to their employees. Now, going beyond the workplace, some have advocated for expanding wellness initiatives to public insurance programs like Medicare and Medicaid. While wellness programs are generally popular, there exists significant debate regarding the effects of these programs. First is, do these programs in fact reduce healthcare costs or improve health? And second is whether the programs merely reward employees who already enjoy healthy behaviors or who are in good health. And if so, the programs could even be discriminatory. Now, unfortunately, the evidence that supports this debate is mixed and limited. A widely cited meta-analysis by Baker, Cutler, and Song found that wellness programs saved about $3 in medical costs for every dollar spent on wellness, and they found similar reductions for absenteeism costs. Now, subsequent review of this evidence found positive cost reductions across these studies, but the estimates were decreasing in study quality. A key challenge is that most of the prior studies are observational, meaning that they compare outcomes between employees who participate in the program to employees who do not participate. Now, wellness program participation is usually voluntary, and so this introduces scope for selection bias, meaning that differences in health outcomes between participants and non-participants might not reflect the causal effect of the intervention, but rather might reflect underlying or pre-existing differences in health or health trends. So to overcome this limitation, we partnered with the University of Illinois to conduct a rigorous impact evaluation of workplace wellness. The University of Illinois was an ideal partner for two main reasons. The first is that they did not have a workplace wellness program at the time, but their peer institutions did, and they were interested in possibly rolling one out. The second was that the administration wanted to know whether workplace wellness was worth the investment. Would they save on healthcare costs? Would it improve health outcomes for the workers? So they were willing to put it to the test. So we designed a large-scale randomized evaluation at the University of Illinois. We introduced a high-quality wellness program that was designed to mimic best practices of wellness programs that are used at other large employers. Now, the University of Illinois is a large and diverse employer. They have more than 12,000 benefits-eligible employees. About a quarter of these are faculty, and the remaining 75% are spread across administrative and union service positions. And the employees in our study were randomly assigned to either a treatment or a control group so that the average causal effect of the intervention, the wellness program, can be calculated using a simple comparison of means across these two groups. So the treatment group would be offered the chance to participate in a 2-year wellness program, while the control group would not be eligible for that program. So the program that we rolled out, the 2-year wellness program, was called I Thrive. It consisted of 3 main components: an annual on-site clinical screening, measuring things like an employee's height, weight, and waist circumference, so their BMI, glucose, blood pressure, cholesterol levels. This clinical screening was followed by an annual health risk assessment, a questionnaire about people's lifestyle and healthy habits to identify health risks. And the third component was that participants in the program could select from a choice of wellness activities each semester. These were things like smoking cessation, chronic disease management, fitness classes. To encourage participation, employees were given paid time off to complete these steps, and were also encouraged with financial incentives of up to $650. In addition to the large sample and randomization, a key strength of our study is the rich data that we have linked at the individual level. We have data on administrative employment measures for all employees. We have health insurance claims from the university's largest health insurer. We have measures of biometric health from the clinical screenings, as well as self-reported measures from annual surveys. This figure is an overview of the study design. The study began by recruiting people into the study out of the 12,000 plus employees that were invited. 4,834 employees agreed to participate in the study by completing a baseline survey. Of these, 3,300 were randomly selected to be in the treatment group, which was eligible to participate in the iThrive program. The remaining 1,534 employees were assigned to a control group, which was not eligible to participate in the wellness program. So in the first year, as shown in this diagram, the treatment group was eligible to participate in the iThrive program, which consisted of a biometric screening, a health risk assessment, and wellness activities for both the fall and spring semesters. After this, there was a one-year follow-up survey and clinical measurement that was conducted for both the control and treatment groups. So we can measure one-year outcomes by comparing differences in means across the treatment and control group. That's the one-year effect. And then the iThrive Wellness Program ran for a second year. Again, all members of the treatment group were eligible, not the control group. And so after 2 years, we could evaluate the two-year effect of the program by comparing outcomes, survey and biometric outcomes measured at the two-year follow-up. Now, one of the power of randomized evaluations is that by random assignment of individuals to treatment and control groups, the idea is that these two groups will be statistically identical or very similar at baseline, and so that the only difference between them is how they're treated. One is exposed to the intervention. And as a result, any differences in outcomes between these two groups can be attributed to the causal effect of the program. So to evaluate whether the randomization was successful, you can look at baseline and just see, does it look, based on the things you can observe, that the treatment of the control groups look similar? And across a variety of demographics, measures of healthcare spending, health behaviors, and productivity, the treatment group and the control groups looked very similar to begin with. As one example, the first row in this table shows that the fraction of the control group that was male was about 42.6%, and the treatment group, 42.8%. So very, very similar. They were similar across all of these measures. And so this boosts our confidence that we can interpret any differences in means in outcomes that occur after the intervention to the causal effect of treatment. But there's two main questions that I'm going to address today. The first is to ask, what would we have estimated the impact of this program to be if we had followed an observational analysis, like many of the prior studies had done, simply looking at people who were eligible to participate in our program, that's the treatment group, and then comparing differences in outcomes between those who chose to participate, which was about 60% of the group, to those who chose not to participate, which was about 40% of the group. Now, any differences that arise from that comparison, the concern is that they might not reflect the causal effect of the program, but might instead at least partly reflect differences in underlying health or health trends that existed to begin with. So we'll look at that directly. The second thing we'll do is we'll do an RCT analysis using the randomized controlled trial. We'll compare how outcomes differ 1 year and 2 years after the intervention began between the treatment group and the control group. And because these groups are statistically very similar to begin with, any differences that emerge over time can be attributed to the causal effect of the wellness program. All right, so this first graphic shows you a summary of the main findings from our observational analysis. So again, for this analysis, we took all individuals who were eligible to participate in the wellness program. These are the individuals in the treatment group. But again, since participation itself was voluntary, they were all eligible, but not all participated. About 60% participated and 40% didn't. What we did is we compared outcomes 1 year after the intervention began between these two groups. So There are 5 outcomes in this graphic that we're looking at. The first one is whether they participated in a running event. So at the University of Illinois is located in Champaign, Urbana, Illinois, and there is a popular running event that occurs every spring called the Illinois Marathon, which consists not only of a marathon, but also shorter races, like a half marathon, a 5K, a 10K. And we look to see whether people in our study ran in that running event. We also look how often they go to the gym, whether or not they terminated employment with the university, how much they spent on hospital care, and their total medical spending. And what you can see is that there are large differences between participants and non-participants, broadly aligning with participants look a lot healthier after 1 year than non-participants. Starting at the top, participants were more than twice as likely to run in a running event. They were nearly twice as likely to go to the gym. They were about half as likely to terminate employment, so they were more likely to stay with the employer. They spent less on hospital care, and they spent less on medical care in total. And so across the board, these look like the wellness program may have had big impacts. However, a concern is that because participation is voluntary, maybe participants were different to begin with. And so what we did is we did the same types of comparisons, but looking at how participants and non-participants looked even before the intervention began, so the intervention could not possibly have affected those outcomes. And what did we find? Well, when we looked at medical spending in the year before the intervention began, participants were already spending less on healthcare. So participants are shown by the orange bar on the right. They were spending on average $433 in the year before the wellness program began. Non-participants were spending significantly more, about $548 a month. So participants were already spending less on healthcare to begin with. And when you look at healthy behaviors like going to the gym, which is the graph on the left, or running in one of the running events on the right, in either case, participants already were much more likely to be engaging in these healthy behaviors. And this causes us to be concerned that differences between participants and non-participants, if they were so large to begin with, then the differences we had observed between these two groups after the intervention began may not reflect the causal effect of the program, but might just reflect selection bias. So to estimate credible causal effects of the program, we turn to the comparison of outcomes between the treatment group and the control group. And again, as we saw before, the treatment group and the control group, by nature of the randomization, were very similar across a broad range of observable characteristics at baseline. And so what we can do is simply compare differences in outcomes between those two groups over time as a measure of the causal effect of the wellness program. And what do we find? Well, if we look at the same figure, these are the same 5 outcomes I showed you for our observational analysis, we see something very different. There are no significant differences across these outcomes when comparing the treatment group to the control group. And just overlaying the RCT estimates in blue to the observational estimates, which are shown in orange, what you can see is that you could have arrived at very different conclusions about the impacts of this study if using an observational analysis rather than using the RCT. Now, one question you might have is, well, if these employees were different to begin with, maybe you could just adjust for those differences by controlling for demographics or observable baseline risk factors. And so in our study, we actually did that. We used machine learning and other sophisticated methods using our big and comprehensive data sets on individual characteristics and controlled for baseline differences. What was the impact on our observational estimates? Well, in some cases, the observational estimates diverged even further from the RCT estimate, suggesting that there are unobservables that drive people to participate in wellness programs, maybe things like intrinsic motivation or a desire to start getting healthier, that are very hard to control for. And as a result, the RCT is a very powerful tool for establishing credible effects of the program. All right, so we demonstrate here the value of an RCT over an observational approach to estimate the impact of wellness. But you might ask, do you need an evaluation at all? Maybe the people who are participating in the program and who see what's going on, maybe their perceptions of the impact are good enough. Maybe they understood that the program, maybe they liked it, but maybe they understood that the program had limited impact. So to try to look at the differences between perceptions and our estimated impact, what we did was we asked people questions about their perceived health. So every year when people would come in for their clinical screening, just prior to the screening, we gave them a health beliefs questionnaire. And what I want to do for today is simply focus on question 4, where we asked people, what do you think the chances are that you have high blood pressure today? So they would report what they thought their chances were of having high blood pressure. And this happened immediately before they would see a nurse who would actually take a blood pressure reading. So we can compare their perception to a clinical measure. And what did we find? Well, when we looked at the perceptions, this is measured after 2 years. So this is after the wellness program has run for 2 years, and we did a clinical screening of individuals in the treatment and control group. What we found is that among the control group who had not had access to the 2-year comprehensive wellness program, they reported an average chance of high blood pressure of 32.4%. The treatment group reported a chance of high blood pressure that was lower. So lower here would indicate a lower chance of high blood pressure or being healthier. So that's a 10% drop in the chance of high blood pressure, and it's statistically significant. Does that accord with the impact that we evaluate, that we estimate of the wellness program on the clinical measure of high blood pressure or hypertension? And the answer is it does not. We found when we did the clinical measure of high blood pressure, we found that in the control group, 50.4% of them had a clinical measure of hypertension. Slightly more actually in the treatment group had a clinical measure of hypertension, although these differences are not statistically significant. All right, so just to wrap up, there are 2 main lessons that we can learn from the Illinois Workplace Wellness Study. The first is that research design matters. Our study underscores the value of using randomized evaluation by demonstrating that an observational analysis of our data, the same data in the same context, yields incorrect results even after we adjust for or attempt to adjust for selection bias using a comprehensive set of demographics and baseline risk factors. A second lesson is that perceptions alone may not be a reliable measure of the realized impact of an intervention. In our setting, causal effects of treatment, we found that the treatment improved some self-reported outcomes after 24 months, but there was no detectable effects on clinical or administrative measures of health outcomes, healthcare use and spending, health behaviors, or employment and productivity. If you have questions, I would be happy to receive them via email and continue this conversation, or you can learn more by visiting the study website, www.nber.org/workplace wellness. Thanks everybody very much.